Welcome everybody to NCAN on YouTube. I am your host, Mike Wayman, for this evening's live stream Q&A. First, before we get anywhere, I do want to thank everybody who joined us on our conference this weekend in Charlotte, North Carolina. It was really, really awesome. Had a great lineup of speakers. Everybody was really engaged. It was a really awesome time. Our next one is in June. We're going to Minneapolis, Minnesota. We're going to have Dr. Thor Halfdanarson there and a whole slew of other great speakers as well. But that's not what we're here for today. Today we are here with Dr. Sarah White. Thank you again for joining us.
Thanks for having me.
We had her on the podcast, the Let's Get Real podcast, this past Wednesday, and this is kind of a little bit of a follow-up, I guess. Dr. Sarah White is an interventional radiologist and a surgical oncologist out of the Medical College of Wisconsin. And yeah, if anybody has any questions, please just throw them in the comments. We're going to get to as many of them as we possibly can. Please don't get too personal with them. We can't really give crazy deep dive diagnosis on a YouTube channel. But let's just try to keep them as general as possible if we can. So how are you, Dr. White?
It's good. It's nice and cold here in Wisconsin. It's about to snow. So
I'm here in New York and it's back in the 30s. It's supposed to be spring. I don't understand this. Yeah. So I'm going to get us kicked off real quick. So a lot of people have, from like the basics and stuff like that. Could you just give us a little bit of a background or a quick difference between stage and grade and what that means to a patient's prognosis?
Sure. So when we talk about grading is usually something that we can do by looking under the microscope. So we'll take a little sample of tissue and then we put it under a microscope, and then the pathologist just count how many of those cells are dividing. And that gives us sort of a mitotic index, and which is the Ki-67 that we all like to refer to. And by that, we would grade the tumor. So grade 1 would be less than 2%. Grade 2 would be 2 to 20%, and anything above 20% would be grade 3. And so that's how we grade it. And that grade just means how quickly those cells are, again, dividing based on what we're looking at under histology. So that will tell us the aggressiveness of the cancer. So if they're dividing rapidly, that means the cancer is likely more aggressive, versus if they don't see any cells growing, it's more of an indolent smoldering kind of cancer. So that's what grade means. Staging is where we find it in the body. So it's a little bit hard to stage metastatic or neuroendocrine if it's, let's say the primary is in the pancreas. So if it's just confined to the pancreas, then you have local tumor. Once it leaves the pancreas and it goes anywhere else, you would be a stage 4. So typically when patients present, especially with carcinoids or something in the small bowel, sometimes we can't even find the primary. And so by the time we find it, it's metastatic, which by definition, if you have something outside of the primary site, that would be a stage 4. So staging is where it is in the body, and grading is what it looks like under the microscope.
Perfect. From the comments here, Mr. B, what does a neoplasm of the pancreas mean?
Good question. We like to use jargon in medicine. Neoplasm is a fancy word for cancer. So neoplasm just means that it's a abnormal growth, and neoplasm typically refers to something that is also known as cancer. You can have benign malignant. Benign means it's something that is growing, just like you could have a freckle, right? That's a benign lesion on your skin, versus melanoma, which would be a cancerous lesion on your skin. So same thing. Neoplasm just means that you have something in your pancreas and it's cancerous. We believe it to be cancerous.
Perfect. What are your thoughts on the NET test?
So explain to me what the NET test is.
Well, it's apparently a test that tests for NET. It's a blood panel that will test for NET. But it doesn't sound like you know too much about it.
Yeah, that's a medical oncologist question. Yeah. I don't want to sound stupid.
So no. It's something that's been coming up a lot in the community is histotrypsy.
Mm-hmm.
Do you have any experience with it? And do you have what are your thoughts on it? And can you explain it to us a little bit if you do have an understanding of it?
Yeah, so histotrypsy is a modality that's very similar to MR-guided focused ultrasound, or HIFU is what we used to call it, which is high frequency ultrasound. So we take an ultrasound beam and we put that beam and we sort of focus it on a certain location within the body. Most commonly, we've been using it for fibroids in women, but MR, when we use that same modality, when we use MR guidance, we've used it in the brain pretty successfully. What MR guided focused ultrasound or HIFU are, but they cause the ultrasound to focus, and it's heat. Histotrypsy is the same thing. We have an ultrasound probe. We focus that ultrasound, those waves, into an area, but instead of using heat, we use cavitation. So you can essentially just think of it as like shaking it really hard. And when you shake it really hard, what happens is it turns to cavitation as opposed to heat, so thermal-based ablation. So by shaking it, it liquefies, so it turns into basically just liquid. We've seen this. We've done tissues. It's really quite amazing. Normally, when we ablate tissue, we'll put either a probe in or we do it, ultrasonically. The tumor is still there, or the tissue is still there. With histotrypsy, it just is demolished, desiccated, and it turns into this liquid. At MCW, we were part of the Hope for Liver trial. One of my junior partners was really quite prominent in the field and had done a lot of research on it. And so we were lucky enough to be one of the sites, one of the first sites to do histotrypsy in the United States on the Hope for Liver trial. That trial is now completed and has published its results in Radiology, with MCW as one of the authors. And really, the data is still pending as to what the cancer outcomes are. The first trial that came out, Hope for Liver, and then the Teresa trial out in Europe, really just talked about safety. Could we do it safely in patients? So the answer to that is yes, we can do it safely at 30 days, which was our endpoint in Hope for Liver. Patients did fine; they were safe, and I've seen these patients over time. And what happens in a normal, minimally invasive therapy like ablation is we typically see the scar from it. In histotrypsy, it just sort of magically is gone, and you don't see it on follow-up imaging. So it's quite an interesting modality. The preclinical data is also fascinating, and there's some talk about whether or not histotrypsy can sort of rev up your immune system and result in what we talk about as the abscopal effect. So that's where we treat one tumor and then we see regression of other tumors in distant sites. So not where we treated, but somewhere else. And there's some preclinical data. And when I say preclinical, that means not in humans, but in animals, that have shown that histotrypsy is able to rev up that immune system. And so if I treat tumor over here sort of melts away. There's not any big, robust data, but certainly it's piqued the interest of many patients around the country, and certainly many of us that are doing cancer therapy. So that's what histotrypsy is, in a long-winded answer.
No, you know what? That's pretty concise. That's shorter than some of the answers I've heard so far. So that was great. Someone is also asking, why don't I have pain with stage 1 in the pancreas?
Yeah, so the pancreas and the liver too are places where you can have cancer, and even sometimes the kidney, where you can go and be diagnosed at stage 4. So the pancreas doesn't have any nerves that would send pain signals to your brain. It's when pancreatic cancer, which tends to be really fibrotic, goes out into the soft tissues and even gets to that bundle of nerves. So the pancreas sits very close to a bundle of nerves called the celiac plexus. And once those fibers from the cancer sort of come out of the pancreas and they hit those nerves, that's when you start to get pain. With cancer in the liver, you don't have pain within the liver. When you grow something in the liver, it doesn't hurt. And so when patients that have pain in the liver or pain related to cancer in the liver, it's when the tumors are on the capsule of the liver. So the liver has this thin lining around it. And so when I'm in the liver, no, but when I go through that thin capsule, that's what hurts. And so if the tumor is living on that capsule or stretching the capsule, we call it capsular stretch, that's when patients would tend to get pain. But many, many times, gallbladder cancer, liver cancer, pancreas cancer, there's just not any nerves that would tell your brain that it hurts, so you wouldn't know. And that's why it's often caught late.
Okay. Can metastasize, or is it only the primary that will metastasize?
So that's an excellent question. Once the cells are out, they can move. And so could a liver go to the lung? Absolutely. So once the cells have sort of figured out how to evade the immune system, right? So when the tumor is localized to one site, it isn't able to move around in blood vessels, move around in through these little channels to get other places. But once it's lost that and the body can't see it, it can move. And so once you move to another site, it can go to other sites from from the metastatic implant.
Perfect. We have Gigi Baker in the comments here. I'm going to try and condense this a little bit because it is a little bit personal and stuff, but it's kind of about palliative care. So she has a PNET, developed diabetes from the lanreotide injections, deals with a number of other things, bipolar, PCOS, and pain management things. Is there, she sees multiple specialists. Is there somebody besides yourself? Are there people who could kind of look at someone's care as a whole, or does that fall on the patient?
So typically your primary care doctor should be putting all of those pieces together and then reaching out for consults for all of the different things, right? So the cancer would go to this doctor, the PCOS would go to an OBGYN, I forget the other symptom, the diabetes would go to an endocrinologist. So I'm using lots of big words to just say what those specialists are. So the diabetes doctor, the PCOS doctor, the cancer doctor. So all of those would be the consultants. But really the person that's in charge of putting all of those things together and figuring out how everything is interrelating would be the primary care doctor. So having a really good primary care doctor, you can either get one in family medicine. So that's one specialty that really focuses on the patient and how do we fit all those pieces together, or you could get somebody from internal medicine. Both of those are excellent specialties that could sort of bring it all together for you.
Okay. All right. Mr. B says, they keep saying that my net is slow growing, so they do an MRI every 6 months. Should I be concerned?
So by slow growing, they've either taken a piece of tissue and they've done a grading of it, means that it's that grade we talked about at the beginning, meaning they looked at it under that microscope and it is not dividing very quickly. So that's one way to tell if it's slow growing. The other way to tell if it's slow growing is as you're doing is to do frequent staging. So depending on if they know the biology of the tumor, and by biology of the tumor, I mean how quickly it's growing, we will either go every 3 months or every 6 months. And depending on the growth pattern, we will 6 months. If you're a slow growing tumor and you don't have sites of disease elsewhere, I think 6 months is probably a very reasonable way to start until we start seeing growth. If we start to see growth, meaning 1 to 2 millimeters or more in that 6 months, then we may go a little bit more frequently to every 3 months. But typically for cancer patients, anywhere between every 3 and 6 months is about what we do for sort of maintenance or staging or ongoing staging.
Okay. Which medications, i.e. immune checkpoints, inhibitors, DLL3, had synergy with histotripsy to elicit an immune response? When is the best time to start those meds with histotripsy? 1 to 3 days later, for example.
Yeah, that's a great question. Again, I don't know any of the data. I just know that there's been some stuff in the preclinical world and we haven't done it in humans. So I would be remiss to even talk about it because I don't think we know enough to know the answer to that. I think that the question is excellent. And I love that question was asked because I think sequencing is critical. And even if in neuroendocrine, we don't know the appropriate sequencing. When do we do PRRT? When do we go change from, lanreotide to everolimus as opposed to doing immunotherapy? So I think that's a really smart question. And I'm glad you're asking that. I just don't think we know the data to be able to answer that question, especially with histotripsy.
Yeah, it is still very, very, very new. Yes. So hopefully soon, hopefully we get more on that. I know that there's going to be a few more machines put out into the States this year. So hopefully that'll help clear some of that up. Mr. B again asking, can I take protein? I guess he's got the
slow growing peanut.
Yes.
Yeah.
No adverse reactions to anything like that.
Nope.
Okay. Lana is asking, have any NET patients had abscopal effect? If yes, is there a registry data to identify which meds they were on?
Yeah, so typically abscopal effect is not seen with medications, which is an interesting question, right? So if you take a medication either orally or injectable, that will treat your body from head to toe. So you wouldn't expect the abscopal effect. The abscopal effect is a term that we use when we're doing local therapy. So I would stick a needle in and I would burn something in some location. I would do Y90, right? So I'd inject teeny tiny little beads that are killing tumors in the liver. And then I would say I treat the left side of the liver, and then the right side of the liver I see regress. I've certainly seen that with bland embolization in the liver. I've seen that with ablation in the liver. I've seen that with Y90 in the liver. And so I certainly have seen it. I don't know of any registries that are following it because it's such a rare occurrence that I'm not sure we would get enough data. And it's hard to know sometimes whether it's the abscopal effect or, as the question just asked, is it the synergistic effect between what I'm doing plus a systemic therapy? I think it's really hard for us to sort of parse that out. But there's no big data about it. In the olden days, we used to say that cryoablation was the one that we would see the abscopal effect in, and cryo is where we stick a needle in and we freeze tissue. The other time, some of my research in my early days was looking at which modality causes the biggest immune response. And what we found is that IRE, or irreversible electroporation, caused the bigger response from the immune system. Now, that wasn't compared to histotripsy because I don't have any preclinical data on that, but irreversible electroporation is basically an ablation modality. So I stick in a needle, I stick in a second needle, and what happens is an electrical current goes between those two needles and it electrocutes anything in between them. And so when we did that type of therapy, that created an abscopal or a sort of revved up immune response. So that's a long-winded answer again to a question that I just don't have the data to tell you that we know when and who would get the abscopal effect. It's just sort of like, wow, that just happened. But there's no real driver and we don't understand it yet.
It's not long-winded, it's thorough.
There you go.
Thorough. And that's what we want. That's what our patients want. NET patients want thorough information. They're hungry for information. We have another histotripsy question, so I'm not sure how deep you can get into it, but it's about the dietary restrictions headed into.
Yeah, so the beauty of histotripsy, and really depending on what organ they're doing, theoretically they should be doing liver. There's a trial for kidney now, but they're basically we give you general anesthesia, and the reason is you have to lay very still and for whatever 20 minutes or however long it takes us to do the histotripsy. And so the only restrictions you would have on diet is what you would need for general anesthesia, and typically that's 8 hours of not eating anything by mouth. But again, it's going to be dependent on your local center. And then when we do the anesthesia, some centers do a little bit of breathing to help reduce the motion in your belly, because when we take deep breaths, the structures in our body move. And so sometimes they'll do some kinds of fancy ventilation, but none of those things really should affect what you can eat. Really, it's just the general anesthesia that you're getting for the histotripsy that would affect your diet.
Great. Again, another histotripsy question from Lana. How do you decide between histotripsy or IRE if a tumor is near critical structure? Critical structure like the colon.
Yeah, so that's a good question. In the trials, the Hope for Liver trial, which was the big trial showing safety, we were not allowed to be close to critical structures. So I think we don't have enough data to say it's safe near a critical structure. IRE, we do have data for that. And so our default is that if it's near a critical structure, you're going to want to do IRE because the chance of having off-target effect is low. Now, I can't say that it's not low with histotripsy. I think that's where we think the niche is, right? I think right next to the colon is a great place because there's no thermal effect of it, but there's no data saying that it's safe there. But I would wager to guess as more data comes in that we will find that would be an equal modality to IRE. Now, what I can tell you is how do we choose IRE versus histotripsy and let's say a tumor that's not near a critical structure Histotripsy has a depth limitation, and we have to be able to identify it now with the current platform. And so we have to be able to see it with ultrasound. So if I can't see it with ultrasound and it's really deep, so if a patient has a lot of soft tissues between the point of entry of the ultrasound beam and the tumor, so 13 centimeters in the trial was how far we could get down. I think their latest generation may be able to go a little bit deeper and penetrate. So then that would be where we would lean on IRE, because we can get that a little bit deeper. So for many patients that have pancreas cancer, because pancreas, as you know, is way far in the back, we would sort of defer to IRE for those types of tumors as opposed to histotripsy. But again, the data's coming in, and so maybe with the evolving technology, we may be able to get deeper into the tissues. The other thing is size. So histotripsy in the Hope for a Liver trial was confined to 3 centimeters, and IRE we can do bigger zones with overlapping ablations. Again, histotripsy we can overlap ablations as well, but that's sort of how we would decide between those modalities.
Perfect. Ann Dabbs from our East Tennessee support group, she's asking, does chronological order of a Y90 treatment change depending upon your primary location? For example, Whipple patients have extra consideration.
Yes.
Any others?
So that's another excellent sequencing question, and I love that people are thinking about this. So in my institution, if a patient is headed towards a Whipple and has liver metastases, then we will really try to get the Y90 done in advance of doing a Whipple if they can't be surgically resected in the liver. Now, you can talk to the surgical oncologist about going into a liver post Y90, but my understanding is that sometimes it can be very challenging to do a debulking of a liver after Y90. So typically mets to the liver, as I'm told by the surgeons, again, not a surgeon, is that they're encapsulated there. So they're in little balls or capsules, so they're easy to enucleate or pull out. And after we do a Y90, it kind of makes it a little bit mushy, and the border between the normal liver and the tumor gets sort of not as easy to distinguish. And so in that instance, we tend to, in patients that have to undergo a Whipple, do a Y90 ahead of that, so we can debulk the liver tumor, again, if they're not able to be resected surgically in the liver. After they've had a Whipple, we certainly can still do a Y90 if mets are developed in the later on. But it gets to be a little bit tricky because the liver, as it is in a body before a Whipple, the bile duct is sort of a clean area. So the bile duct, I like to think of the bile duct as like a tree. And so these are the branches of the tree. The tree comes down to the trunk, and at the bottom of the trunk is a sphincter. And it's a really tight muscle that holds the bile in the liver. And then at certain points, it will open and release the bile. So the reason that we make bile is that it helps us digest food. So we eat food, usually fatty food. The liver makes the bile. And typically, I call the garage of the liver is the gallbladder. So the liver will make the bile all the time. It goes in the gallbladder, it sits there. And then when you eat fatty food, the stomach will send a signal to the gallbladder and say, here's something coming for you. We need you to release the bile to help us digest. The gallbladder will squeeze, the bile will come down. That sphincter at the bottom of the tree trunk will open, and that bile will come out. And so there's not a communication between the intestine at the bottom of that sphincter, the intestine. And so this is a clean system. After we do a Whipple, what happens is this sphincter goes away. And so the trunk of the tree is wide open. And so as the liver makes bile, it will drip down into the intestine. And that's okay. The problem is what's in the intestine can now come up. So all that bacteria that's in your intestine can come up into the biliary tree. If it comes up and you get infection, that's called cholangitis. And so we call the tree after a Whipple contaminated, just because that tree trunk, there's not that sphincter in between them. And so your risk of getting an infection after you've had a Whipple, if we do any sort of liver-directed therapy, can go up. So it's a very high risk when we do things like bland embolization or chemoembolization. Very, very high risk of developing an infection, and even a 25% mortality if you do get an infection. So we will shy away from doing that, or even an ablation, because of that contaminated biliary tree. With a Y90, there's an 8% risk of infection. So we can still do it. We just have to be very careful about it, and just know that you're at an increased risk of developing an infection after a Whipple. So the sequencing is really critical. If we can do it ahead, we will, but certainly on the back end, we can still do it. We're just limited by which modality we can use, and ablation would not be a modality we would use. Bland and TACE, we have to be very, very careful if we offer it at all. And Y90, again, an 8% risk of infection.
Great. Is it possible, Pamela J is asking, is it possible cancer will just stay in lymph system, not organs? So I guess, will it just stay in the lymph nodes or and not head to the organs?
Well, cancer is a very special thing, and it can do whatever it wants to do. So if we're talking about certain kinds of cancer are just in the lymph nodes, right? So the lymphomas of the world, those are lymph node cancers, and they tend to stay in the lymph nodes. Cancers like metastatic neuroendocrine, once they sort of break out and they move, they tend to move in to certain places. The reason metastatic neuroendocrine tends to go to the liver and not just stay in the lymph nodes is because the drainage of all the intestines is through the portal circulation and goes to the liver. So could it just stay in the lymph nodes? It certainly could. We see that sometimes where we see the primary tumor and then the lymph nodes around the primary have cancer in it, and then it doesn't go any further than that. We've certainly seen that. If you're getting treated and it's in the lymph nodes and it's not moving, I've certainly seen that as well. So can it happen? Absolutely, it can happen. And if we're getting treatment and we have stable disease and the treatment is helping, absolutely. But eventually, will it go to other organs? Probably.
Okay. I think this is an interesting question because it's not like a specific medical question, but it is part of our mission here at NCAN. But I'd like to know your thoughts too. Mr. B again wants to know why is there little information on NET? Because his doctors act lost for answers.
So now we're getting into the theoretical, what's happening. Yeah, so I think, metastatic neuroendocrine and many of the cancers that I in particular treat as an interventional radiologist are what we used to consider rare. If we look at the incidence and prevalence of metastatic neuroendocrine, lung cancer sort of, looks like this. It's sort of a straight line, maybe a little bit of an increase. Colon cancer, breast cancer, they're all sort of plateaued or a straight line. Metastatic neuroendocrine, if we look at it, goes like this, right? So it's a prompt rise. And so I think the answer to the question is not a lot of people know about it because it was a rare disease for a long, long time. Do I think that the incidence and prevalence, meaning how many have it and how many in a year get diagnosed, is changed a whole lot? I think the reason for that is we become smarter and we're able to diagnose it more. I think metastatic neuroendocrine is a really tricky cancer to treat, and I think that's probably why many people don't know about it. Again, a rare disease. And really, when you get a rare disease like that, that's complicated to treat, I think the big tertiary, quaternary centers are the ones that really have expertise in it. But when we get out to other sites, it's not well known. It's the same thing as many, many diseases, right? You can go to your primary care for many things, but it's at some point you're going to have to go see a specialist. And I think that's where, when you have metastatic neuroendocrine, you're going to be your own advocate, as we talk about a lot with you all. But it's just, I think it's just sort of a rare disease. And because many patients with metastatic neuroendocrine seek out high-level care, it's really the base of the care is at the big centers. And that's why there's a group of us that treat it and know it well. And there's a group that says, you know what, this is beyond my expertise, and I'm going to send you all to the sort of big centers. So it's not a great answer, but I think that's probably why.
I don't think there'll ever be a great answer for it personally. Yeah. It's very hard. It's it's keeping up with different diagnoses that pop up all the time, and it's still rare. So that's probably the best answer we can give. It is still rare, but luckily, 20 some odd years ago, there was no information. Mm-hmm. And now look at where we are. This isn't even the only live stream that exists for patients to ask these questions for. So we're getting there. It takes time. It takes time for sure. Pamela J again asking, Can you repeat PRRT treatment, and what is the time frame that you should exercise between treatments?
So that's a really excellent question. And I think, again, we're still learning. I'm not a PRRT expert, but what I can tell you is it depends on how many cycles of PRRT you've had, and it depends on where your disease is. And so without knowing the specifics, the answer to your question is yes, you can have it. And how the length of time between treatments really will depend on how many treatments you've had and your location of disease. So if it's in the bone, have you had adverse events from it? If it's in the liver. So it really, I think it depends on how you tolerate it the first time, what your off-target toxicities were, or what your toxicities were, and then where the disease was primarily and where it is now. So the short answer is yes. The long answer is it depends.
Right. Should I be concerned with getting a cyst on the head and tail of my pancreas?
Yeah, cysts are pretty common, and it depends on what kind of cyst you can have. The radiologist usually in their report will tell you the type of cyst it is, and they'll tell you the frequency or the interval with which you should get it followed up. We have something called an IPMN. I mean, I could go through all the different kinds of cysts, but the bottom line is that you can have a cyst just like you could have a cyst on your skin, right? People have cysts in their nerves, and they're not going to be dangerous. But really, it's going to be up to what that radiologist says, the words that they're using, because as they describe it, they will tell you what their prediction on whether it is bad. If it looks a little aggressive, it looks like just more than a cyst, or if this is just a cyst and we don't need to follow it up anymore. So really looking at that radiologist report and see what it says, and what it says for follow-up will tell you what kind of cyst it is. And cysts can be benign, meaning we don't have to worry about them. And cysts can be like, don't like the look of that. I'm going to want you to follow up sometimes yearly, sometimes, again, 3 or 6 months. So really read that radiology report, or if you don't understand it, have your primary care or one of your physicians read it, because they'll understand. And if they don't, they can call the radiologist.
Great. Gigi Baker back asking about here's like the actual palliative care question that she has. What are the qualifications for it to begin? When do you use it, and when is it needed?
Yeah, I think palliative care is a very, very powerful tool, and I use it in the majority of my patients. And I'll tell you why. So Jennifer Temmel she worked at Mass General, and in 2009 she published an article in the New England Journal. And what she looked at patients, again, not metastatic neuroendocrine, but she looked at patients that had lung cancer. And so there were two groups of people. So both of them got systemic therapy and radiation and surgery and whatever they needed from the physician standpoint. So the two groups, exact same kind of cancer, exact same treatments, but one of the groups got palliative care, and the group that got palliative care folded in early had a prolonged survival by 3 months. So when we talk about systemic therapy, sometimes 3 months, as oncologists, we pat ourselves on the back. Ooh, I got 3 months survival. They did nothing. All they did was fold in palliative care. So palliative care is the group of physicians that focus on control of symptoms. So symptom management. They will talk to you about death and dying. They will talk to you about advanced directives. So having those discussions and having symptom management prolonged your life by 3 months. So I talk to patients all the time about, let's make sure that your symptoms are under control. And we have talked about death and dying. And, you fold it in with different patients at different times. But if you're really struggling with symptoms, I think that's the time to get palliative care involved. I just want to make sure that we understand the difference between palliative care and pain doctors. So pain doctors are patients that are physicians that will manage chronic pain. So if you've fallen and you have excruciating back pain from a fall years ago, that's what a chronic pain doctor will do, because they're really good at how do you manage pain for a long period of time, as opposed to the palliative doctors who are dealing with sort of this cancer-related pain. It's not maybe a chronic years and years and years, but the ebbs and flows that happen with cancer therapy, the nausea that happens, what kind of pain medication I can't swallow because of the chemo, or I have sores in my mouth because of the radiation. And they're the ones that are really experts in trying to help mitigate all of those side effects and symptoms. And then again, the discussions about death and dying are something that palliative care can really help with. So in my cancer patients that, my metastatic neuroendocrines, depending on where you are in your journey, you may or may not be symptomatic. And we can certainly fold them in the mix whenever we feel like they're helpful. But again, I use them, I lean on them a lot because they're excellent group of an excellent team to help with managing all those things.
Awesome. A direct radiology question here. Can you explain the difference between bland embolization and chemoembolization?
Absolutely. So the liver is a most amazing organ in the body. So the liver has two blood supplies. So one of the blood supplies comes from the intestine. And the reason we have that is that the liver's job is to filter out toxins. And so what happens is I eat something, and with that food comes toxins. And so the body's way of getting that food and all of the things that it absorbs from the food to be filtered through the liver is that it absorbs all of those things into a network of blood vessels called the portal circulation. So those blood vessels go directly from the intestine and they come up to the liver, filters out through the liver, and goes back to the regular blood flow. So the blood flow that goes to the rest of your body. So what happens is that the liver also needs the oxygenated blood that comes from your heart. So the blood goes to your heart, pumps out, and it goes into your liver. So that blood is oxygenated. So the liver likes both. The liver likes the dirty blood coming from the intestine a little bit better. So it gets about probably 2/3 of its blood supply from that portal vein, from the intestinal blood, and it gets about 1/3 of its blood supply from the heart, or the clean blood, the arteries. So what happens when we do embolization, I'm just going to start with embolization. So embolization is blocking off the blood supply to the tumor. And so why does that work? It works because the tumors don't like that dirty blood. The tumors like clean blood because what they need to grow is oxygen. And so what happens when we do embolization, we go into the artery that supplies the tumor. We infuse little things, and those little things plug up the artery, and that tumor behind it dies because it can't handle the dirty blood. It doesn't get supply from that dirty blood, so it dies while the liver stays alive. So that's the word embolization. So what bland embolization means is those little things that I'm infusing into the liver are just little plugs. That's all they do. They're little plugs. They don't harbor any chemotherapy. Chemoembolization is where I go into that same artery, and instead of just putting little plugs or corks into the blood vessels, before I do that, I infuse chemotherapy. That chemotherapy is a mixture of things. So there's 3 drugs that I use in my practice. Doxorubicin, mitomycin, and cisplatin is what we use. And that was a therapy that was developed years and years ago, 20-something years ago. And we mix it with an oil, so it becomes a chemo emulsion. And we infuse that because it's like a sticky, thick paste. We put it in there, and it goes and it deeply penetrates into the tumor so that we can get deep penetration by this liquid, as opposed to those beads, which sometimes can get lodged a little bit further back in the artery. So that's the difference. The chemo has the chemo that we put in first, and then we put the corks afterwards. And the bland embolization is where we do not have that liquid. We just use the teeny tiny little particles that act as corks to block the blood supply.
Great. Rebecca is asking, and I could kind of answer some of this as well. How can we find the big centers? My dad has net cancer and is getting treatment. How do you find the big centers? Networking, talking to organizations like us, NCAN. Call the hotline. Don't be afraid to call the hotline. It's there for a reason. 9 a.m. to 9 p.m. Monday through Sunday, Eastern Standard Time. My mother will answer the phone. She will tell you.
I was going to say Marianne.
she'll tell you where those centers are. Talking with other patients, finding support groups, finding people local. You may not have a center by you, and that's okay. There might be some that you might have to take a trip to, but they will happily work with your doctors. And she's chiming in there. My mom, Marianne, is in the comments as well, so she can definitely send you to the right places. But there are plenty across the country, and sometimes it just takes one trip and having them work with your primary doctors in your location to get things rolling. So definitely.
Yeah, and I'll just reiterate that in the time since COVID, now we do virtual visits a lot. So if you're really remote and you can't get down to a big quaternary center like Frederick Hospital, which is where I work, I do virtual visits all the time. Sometimes you have to come down here if it's a procedure, but we work with local medical oncologists all the time. So what happens is they'll come down to us, or we'll do a virtual visit, and we'll figure out the plan of care, and then we'll send that and talk to the local oncologist. They'll implement that plan, and then we sort of stay in the fold every 3 to 6 months. We'll see you virtually. So even though you don't live by a big center, that doesn't mean that you can't get the advice and the opinions and have us help drive care, because we are the cutting edge and we know the research and we know all the clinical trials. So just because you're remote, don't be afraid to call us. And certainly I do virtual visits. Probably half of my clinic now is virtual. So I'm happy to do those calls remotely. Great.
I don't know if you see any of these, but there are a lot. Ann Dabbs was thanking you for your explanation about her question. Mr. B as well, and Gigi saying that you everything that you've been doing so far, these past 41 minutes and change, has really helped everybody a lot. Rebecca as well. So thank you for taking this time. We still do have a few more questions. Lana's asking a little bit more about histotripsy. Have you heard of any net patients who have had abscopal effect with following histotripsy? You said there's little data, but there are net providers speculating. But are there any net providers speculating on any types of meds which may work synergistically? Too early to tell.
Too early to tell. I mean, theoretically, we would think that anything that revs up your immune system, so all the immunotherapy, should be what we would use. But again, we thought that with VEGF inhibitors with liver cancer, and it turned out that wasn't the answer. So I could speculate, but I probably would be wrong. Because data is better than my speculation. So
it's still in the early stages of the histotripsy stuff. So it looks promising, but we don't have any solid data just yet. After how many years of use can SSAs cause diabetes and or pancreatic enzyme suppression?
Yeah, that's another great question. I think I'm going to have to defer that to the medical oncologists. I've seen patients on it for long periods of time. I've also seen patients on it for short periods of time that have had it. So I think it's going to be patient dependent, but really to get a better answer, I think medical oncology is a better person to ask than me. Sorry.
Nope. How are the stats on alpha PRRT renal toxicities and potential for
myelodysplasia?
Myelodysplasia better than Lutathera?
Yeah. So again, that's going to be a question better towards your medical oncologist or the people that do PRRT. I certainly have seen those side effects. But again, I don't know the exact data on that. Sorry. Good question though.
I have a question. Oh, we have why does my blood count stay high, Mr. B?
Blood count.
White blood count, white cell blood count.
I guess I'd have to understand what caused it to go high. Sometimes white blood cell counts can go high because of steroids. If you're on a steroid, that can go high. But I guess I'd have to understand the entire treatment algorithm to understand why things are misproportionately high.
Great. Yeah, that's a little bit more information, a little bit more personalized question. Is Y90 still being used? Is it still a thing?
Good question, Marianne. So I just figured out how to look at the comments. So now I'm with you. Sorry, it took me this long. I was like on some other chat click button. Yeah, so the answer to that is yes, Y90 is being used all the time. You just have to be very careful. And I say this a lot to metastatic neuroendocrine patients, is that you have to remember that Y90 is a really big and powerful tool, and we just have to be very careful and thoughtful about when and how we use it. So in patients that have long longevity, like patients with metastatic neuroendocrine, we just have to think about what is our life expectancy. So with patients with grade 3, I certainly would think about using Y90 sort of in the first line, or once we're really getting into the thick of things, because we know that life expectancy is going to be a little bit shorter for those patients. And we really want to do something to slow down the progress of the disease. With patients with grade 2s, I tend to not use a Y90 unless the patient is in a catabolic state. And what I mean by that, if the cancer is so overwhelming that they're not able to maintain their weight, the cancer is just sort of taking all of their energy away, then in those patients, we have to settle it down very quickly. And the third set of patients that we'll use it on, so rapidly progressing is one, I say grade 3, but rapidly progressing, and a patient that's catabolic, so their tumors may be sort of there, and maybe it's an early diagnosis, but they just can't maintain any weight they're eating, and it's just the tumors are taking over all of the energy. And then the third group of patients that I would say is that if we're in a situation where we can't do systemic therapy, or they can't tolerate any of the other therapies because their performance status is a little shaky. And by performance status, I mean if a patient's energy levels are pretty low, and I don't think that they could tolerate the other embolizations, because those are a little bit more challenging to tolerate, even though the profiles are pretty good for all of them. Those are the 3 patient populations that I would consider Y90. And then maybe the sort of star caveat off to the side is if you have a single lesion and you're post-Whipple, we may do what's called a radiation segmentectomy. So we'd use radiation to basically wedge out a piece of the liver as though you have had an ablation. So those are the 3. Again, that 4th asterisk over to the side, you'd have to be very careful about it, but we certainly think about it in those instances. So yes, still alive and well in NET patients, just have to be very, very thoughtful. I would never use it in a slow growing patient that's got, low liver volume disease. That's not the right patient. And if somebody's telling you that, then think again and come see a big center or get a second opinion.
Great. Okay, I could probably do about 4 more. We've been getting a kind of a surge when it comes to our conferences and people reaching out, where there is a younger demographic kind of being a little bit more prevalent in the NET space. When it comes to interventional radiology, how do some of the treatments impact fertility?
Yeah, so that's a great question. It shouldn't affect fertility at all. We are nowhere near anything that's causing hormonal release. So it really doesn't affect it. We're doing local therapy that doesn't go systemic when we're doing Y90 chemotherapy. You will have a sort of a peak in the first 24 hours, and then you'll have the rest of it will be sort of cleaned out of your system. So it shouldn't affect your fertility at all, is the short answer to that. So there should be no effect. It's
Right.
not like when you give something systemically, we're giving it really local and targeted.
Sure. If the effects of SSAs start to diminish, what is the next level of neurosurgical treatment? I have a gastronoma.
So non-surgical treatment for gastronoma, it depends on if it's primary, so the primary, or if it's something else. If it's the primary that is getting bigger, depending on where it is. If there's metastatic implants, then we certainly could do local therapy. And we tend to use local therapy if we have oligoprogression. And what that means is if you have your primary in somewhere and that's stable, but let's say you have something in your lung that's getting bigger, maybe you have 2 things in your lung that are getting bigger, do we move on to the next systemic chemo, so the chemo that goes to your whole body, or do we just treat those 2 sites? And what we've evolved to over the last probably 5 to 10 years is let's do local therapy, because there's some data saying if we can treat those 2 sites, but everything else is staying stable, that we would treat those sites locally with ablation. Like those 2 lesions I talked about in the lung, I'd stick a needle in both of those, kill those, and then continue with the SSA. When we would move beyond SSA to another systemic agent would be if we're seeing progression at all sites. So we have multiple sites and all of them are progressing. That's the time that we would think, okay, let's move on to the next therapy, instead of just, can we get this one site that's progressing, or this oligo progression, as we call it.
Great. I'm not sure if we have a great answer for Freedom here in the chat. He's asking that, he's saying that his wife is on Lutathera for her liver cancer. Do you think that treatment can work for cancer, liver cancer? I mean, Dr. White, do you?
So I've never used Lutathera for liver cancer. If we're talking about liver metastasis, yes, the answer is yes.
Yeah.
We've seen it for metastatic neuroendocrine, but I've never seen it used for primary liver cancer. So the two primary liver cancers are cholangiocarcinoma and hepatocellular carcinoma. I've not seen it used for those two. But certainly Y90 or the bland or the chemoembolization that I've talked about earlier, both of those could be used for primary liver cancer and have been used very successfully. And we have a lot of data on that.
Great. And last question, looking toward the future, we've on the podcast, we talked a little bit about clinical trials and stuff like that. Mm-hmm. In the world of interventional radiology, what kind of new things are on the horizon?
Yeah, that's a great question. So reported out a couple weeks ago, and we're still sort of getting the data, is our RetNet, because I want to talk about what's coming like soon. So you guys are at the edge of your seat waiting for this data. We've been waiting for a long time. So RetNet was our big trial. It was a randomized trial looking at patients that had liver dominant metastatic disease. And what we looked at was patients underwent either chemoembolization or bland embolization or drug-eluting bead. So those are the three groups. It was I say two, but actually when the trial started, it was all three groups. So drug-eluting bead, I talked about two of them. The third is drug-eluting bead. And those are those little corks, just have cancer or chemotherapy embedded into the bead itself. And so that chemotherapy would release as the bead gets lodged into the blood vessel. So the results of the RetNet trial are starting to be reported. The first report out was at our big annual meeting, Society of Interventional Oncology, which took place in January. Michael Sulin was the PI of that. And all of that data is starting to come out as to which one is the winner. And so I think that is the future, is we're going to find out which one, as we talked about earlier, what's the difference? Well, mm-hmm. This is what the difference is, but I think the data is going to tell us who should use them. What we do know from that data already is that drug-eluting beads, we don't do anymore after the first 30 patients. They had so many serious adverse events in the drug-eluting bead arm that we don't do that anymore for metastatic neuroendocrine patients. So we may not have a winner ultimately, but we certainly have a loser. So drug-eluting beads is out. And so the data is coming out about which of those. So that's what I'm excited to hear about, which one of those we should be using in patients, because I think that's going to help us sort of stratify the patients into those two categories. So that's what I'm hopeful for. We're going to find that out pretty soon here.
Awesome. Dr. White, thank you so much for spending your time with us, so much of it this month. Between the podcast and here, the reception from the listeners of the podcast and the people here, they can't thank you enough for imparting all this knowledge on us and answering everybody's questions. Everybody at home, please go to netcancerawareness.org. That's where you can find all of the things going on with NCAN. We have our conference coming up in June in Minneapolis. We have another one. We have our reschedule of our Birmingham, Alabama one in July. We have another one in New Jersey coming up in October. We have a lot of fundraisers. If you're in the Long Island area, May 3rd, we're going to be having a fundraiser at the St. James Brewery here in Long Island, New York. We have our Flower Power winding up here at the end of this month. We have a Mother's Day promotion starting tomorrow. So please just go to netcancerawareness.org. It's going to have all of that information there for you. Or you can reach out to us on social media at netcanceraware. Don't forget that we also do have the hotline. It is open for about another hour. Eastern Standard Time, everybody. The number is 866-850-9555. There's a very good chance, there's 100% chance that you're going to talk to my mother if you call that number. And if you have any questions about finding a center, finding the best care around you, she's a wealth of information. So go ahead and do that. And yeah, we'll see you next month. In June for our next one. And thank you again, Dr. White.
Yes, thanks. It's always an honor and a pleasure to be here. So I appreciate the time.
Great. Thank you. Thanks, everybody.